Welcome you all to this afternoon. I'd like to welcome Prof. Yang. Prof. Yang, he is a professor in the Department of Anesthesia and Pain Medicine, University of Ottawa, and he is the Director of Professionalism at the same university. Professor Yang has very extensive and wealthy experience in the education and the training programs and training in Canada. As well as that, he did a lot of research, and he has a special interest in the perioperative medicine. And if you behave yourself, Professor Yang might play music at the end of the session, because Professor Yang is a professional music player in orchestra as well. So please welcome Professor Yang to this session. Thank you.
I will start talking about, my topic is about preoperative cardiac optimization. And it is an area that many of us wish there were something that we could do to say, this patient is going to be fine when we do surgery. Unfortunately, I think I would say at the end of the lecture, that's not necessarily the case. Thank you. And I'll give you the reason as I go along. So, the objectives, I guess we don't have a projection there, eh? So, as I'm getting older, I can't see on the side. So, the first thing that we would talk about is what is the state of preoperative screening as we know right now, and we'll try and understand the context of preoperative screening. We also will talk about the understanding of the pathogenesis of preoperative myocardial ischemia infarct. So we are focusing really on the ischemic side of the issue rather than vascular, valvular disease or cerebrovascular accidents. And we're going to talk about the potential of how an echo can change. Thank you. Excellent. So we are helped in the sense that there is already an algorithm that the American Heart Association and the American College of Cardiology have put out. And this algorithm is well referenced. It came out in 2014, has been disseminated through a number of organizations, and it's easily searchable on the web for free. So it's not something that is hidden. And you can easily look at the algorithm. If people want me to go into the algorithm in detail, I will, but because of the 20 minutes, I think I will try and spend the time better in giving you the overview of what's going on than actually the actual algorithm steps. One thing I do want to point out is if you look at the algorithm, there are colors of the boxes. That reflects the level of evidence that the American Heart Association has come up with. And you see the yellow, which is class 2 evidence, and you see the red, which is class 3 evidence. Essentially, I will go into the more detail, but it's not class 1 evidence. The only thing that is class 1 evidence is the green box, and you see the algorithm coming down. That reflects the state of our science, which means we really don't have class 1 evidence to do a lot of the things that we think we should do. Having said that, I don't want you to think that there is nothing we can do and therefore we should just go ahead regardless, and I will emphasize what the difference there is. In comparison, there we go. In comparison, this is the algorithm that came out in 2014 at the same time, looking at the dual antiplatelet therapy when patients who have a coronary stent coming for surgery. And you can see most of the evidence is class 1 evidence, and that's green box. So you have 3 green boxes and just 1 yellow boxes. There are no red boxes. It reflects that the state of evidence has advanced so fast for the coronary stents because If you recall, even 6-7 years ago, we were struggling to understand what to do with those patients. But the cardiologists have really stepped up to the plate and answered many of those questions. So that is the state, unfortunately, for pre-op testing when we're talking about anesthesia and perioperative care. But when we're talking about coronary stents, we actually have very good evidence. I'm not going to go into this algorithm for sure because I understand the next talk is on that. The first thing that we have to talk about is optimization. When we say optimization, it really infers three things: that we have a test that we can do, and from that test we can identify what the problem is, what the pathology is, and from there we can do something about it. That's what optimization is. Unfortunately, the evidence is not very good in how much we can optimize. This is a graph looking at mortality, and if you see the three lines, the bottom line is the mortality between 2000 to 2008, and it's a vascular group of patients that they've been working on, and the top line is looking at how much beta blockers those patients received. And the emphasis in that paper was to say that increasing the number of beta blockers did not change the mortality in vascular patients. But more importantly, there are a number of studies which will confirm the same finding. Our mortality in high-risk patients, we have not been able to change. It just stays the same. So that becomes a major issue when we say that we can optimize the care of these patients. One of the reasons is this plot. This was published in the Canadian Journal, but there are other plots similar to this, other studies similar to this. And what essentially David Wong found with the senior author is that when you do revascularization, does it affect post-op mortality? That means before the patient comes to surgery, you find coronary artery disease, and you say, okay, we go and do a revascularization, put in a stent or we put in the cabbage as a procedure. Does it actually change outcome? No, it doesn't. It doesn't change post-op mortality. Does it change post-op AMI? Well, it doesn't. So that really puts a big damper, as we say, we can optimize the patient when we actually are not changing outcome, and we don't seem to be able to change the outcome. It's very unfortunate because most of the things that we are seeing potentially changing outcome, and most of us are seeing that in big database analysis, and that's the minimal invasive surgery, as well as the intervention radiology. So I'm talking about, previously we would talk about an open AAA procedure. Now we're talking about an EVAR, a stent in the aortic aneurysm. Previously we would talk about a laparotomy for a bowel resection. Now we're talking about a minimal invasive surgery with laparoscopy and incisions about this big. They get the bowel out and that's it. That actually evidence is stronger and stronger to show that it reduces mortality and immediate 30-day mortality and morbidity. Not what we've been trying to do, unfortunately. Is this new? It's not. In 1995, Mason actually did a study looking at decision analysis. I showed you the diagram just so you know that it's quite rigorous as a study on decision analysis. But essentially what they found was if you take a deep breath and you go ahead with vascular surgery in the face of a patient with some angina, that actually is not that bad compared to if you do all the angioplasty, angiography. The only group that actually had a higher risk was a group of patients where you know there's inoperable coronary artery disease when you've done all the investigations and you still go ahead with the surgery, then you end up with a higher mortality, 3.8%. And the reason for that was simply you're subjecting the patient to additional risks, angiography, whatever coronary revascularization procedure, and at the end of it, you do the index surgery. So you're subjecting the patient to 3 risks as opposed to just take a deep breath and do the surgery. That was 1995. So it's sad that we haven't really come that far in how we can optimize. Oops, I think I might have jumped. Anyways, the American... Okay, now the only new piece of evidence that has come up, and I apologize, I seem to have trouble controlling the slides. The only new piece of evidence that has come up is a recent article, and the American Heart Association guidelines actually refers to it. When the patients have an acute MI, and then they go on to have either a PCI or some sort of angioplasty stent versus a CABG, and then they come for surgery, a non-cardiac surgery. If it is done within a month, the risk is much higher. And compared between PCI versus CABG, CABG is actually much better in terms of reinfarction. And so what does that mean? Well, that means, number one, we should delay the surgery to 2 months if someone has an acute MI and then they have to come for surgery. At least 1 month, if at all possible. It also suggests that maybe if someone has an acute MI and you have to do a procedure, a CABG might be better off. But the evidence is still just one study, maybe still weak, and certainly the Heart Association did not put that out as a recommendation. They highlighted that there's something there that we need to look at. What is also important for us to know is that this is in a group of patients with acute MI, and then you decide what to do. That's quite different from somebody who has angina coming for a non-cardiac surgery, and then you decide what to do. So those are 2 different denominators, 2 different populations. So don't confuse the finding of this study versus what I just said in the last 4 slides. So, what the Heart Association has done is to classify the level of evidence. And Class 1 is randomized control trial. Class 2 is number of studies. Some are for, some are against. 2A is in favor. 2B is maybe not so in favor. 3 is definitely it may do harm. And the level of evidence is also classified into A, B, and C. And A is definitely its broad spectrum number of randomized control trials. Level B is it's a very narrow population, maybe one single population, colorectal surgery or vascular surgery, and it's not necessarily generalizable to all the different populations. And this is how they look at the evidence. And if you recall the first slide I showed you, for pre-op testing and screening, there was no green box except for 1, and all the other ones were yellow, as well as 1 red, which means very little evidence for Class 1. And the Class 1, if you look at it closely, is if you find some disease, coronary artery disease, in the pre-op testing for a non-cardiac surgery, what you should do is to determine if the patient's coronary artery disease status warrants any revascularization. If not, you proceed with surgery. If you see triple vessel disease, if you see LV dysfunction, the usual indication for coronary artery intervention, then you would proceed with the coronary artery intervention. If you actually think back in your population, I don't know your practice obviously, but in my practice,